Good evening. Hello. Namaste. There was one particular recall question. A DJ stent was shown and asked a DJ stent. You can see the DJ, double J. You can see one J here and at the other end there is a J. That is why it's called a DJ. How would you remove this stent? And some various options were given. Now, as usual, we cannot be dead correct about the options. So I will take you through why a DJ stent is used, what are the problems, and how you can remove them. Now, the double J stents, also known as in short form DJ stents, they are indwelling ureteric stents, the ureters, that allow urine to drain unimpeded from the renal pelvis to the urinary bladder. There is some issue here that it's not allowing the urine to come down into the bladder. So you put a stent and there is unimpeded flow of urine into the bladder. Now, what can it be used for? It can be used if there is a block somewhere. You can negotiate it by the side of the block, number one. Number two, it can be for urinary diversion also. And number three, in case you have done a surgery on the ureter, you can put the stent across. One, it will act like a template for healing. And number two, the urinary stream will keep flowing. Done. And any other obstruction outside, you can put a stent and keep the passage patent. Now, obstructive uropathy, if there is a problem here, right from the pelvis up to the ureters, into the bladder and up to the external urethral meatus, if it is obstructed, there is something known as an obstructive uropathy. There is back pressure on the kidney. There is a renal deterioration. So, the pathophysiology is a renal deterioration. And the problems can be from here up to the external meatus. It can be in the lumen, in the walls of the lumen, or outside the lumen. For example, it can be inside the bladder wall. It can be inside the lumen. It can be outside the bladder. Similarly, in the ureters. In young and middle-aged patients, renal calculi will block the system somewhere. In females, it is gynecological problems or obstetric surgery. You have injured the ureter probably during a hysterectomy or a C-section. Usually you do not injure. But in an hysterectomy or an ovarian cyst, you are likely to injure. In old people, it is malignancy. Either malignancy outside the system or malignancy inside the system itself. And these are potentially life-threatening because there is back pressure on the kidney. Now, what can you do? You can divert this urine. There is a backlog. Divert it somehow. One, you can put a stent. There is an obstruction here, all right. But your stent will go by the side of the obstruction and keep channel open. Or you can do a nephrostomy. You can make a passage into the pelvis of the kidney itself and drain it from here. So now after putting a stent, how can you remove it? You have put in a stent. How do you remove? You will do a cystoscopy. Put a cystoscope into the bladder. Under direct vision, you can pull this stent out. Or there is something known as a string method. This is something like your copper T. The stent itself has a string attached to it. So when you put it inside the bladder in the first time, in the index surgery, the string will be outside the urethral meatus. So it can be pulled out. Now it doesn't need visualization at all. Or what you can do is, through a nephrostomy tract, if there was a nephrostomy tract, because most of the time your obstructions will need more than one modality of treatment. If you have had a nephrostomy tract, you can pull this out through the tract itself. But for that you need a fluoroscopy. See here, you need a cystoscopy. Here you need no visualization, but here you will need a fluoroscopy. Fluoroscopy is nothing but your X-ray imaging. Now, these are in the shape of J. They are malleable. They can be straightened out and pushed into the ureters. But they have to be removed at the appropriate time. So when you put stents, they should be monitored while they are in place. They should be promptly removed, or if they knew they are going to be indwelling, then they need to be changed periodically. You can't put a stent, the surgeon will forget, the patient will forget. No, that is not right clinical practices. Stents are made of polyurethane and silicone. Ureteral stents are associated with complications including infection, encrustation, migration, hematuria, and discomfort that can be caused by tissue irritation. Now coming to the complications, this is from LinkedIn. He is Professor Munim Khan. You have these things. Why you put the J? So that it will not migrate. They act like sort of self-retaining. But they can migrate also. With all these checks, they can still migrate. You see this stent has completely migrated and come off into the urethra itself. Or it can get completely curled up into the bladder. That is your stent migration. Number two, if the stent is forgotten, it can get encrusted. You see, so much of calcium has got deposited. After all, the stent is a foreign body. And the stent can get completely entangled. You can see that it is completely entangled. You can see it's completely entangled in a stone there. And this is your encrustation. And these kidneys are anyway continuing to form stones. Look at the plain X-ray. This is a stone already. And this is the encrustation going on. And this is the tangled lower end of the stent. Regarding stent and infections, anything indwelling foreign body is going to initiate infection. I just want to tell you one lady, our own personal collection. She walks into the OPD saying she's having severe pain here. That's all history will be available. Nothing more will be available. They are not going to come and give you a clinical pathological exercise to you to make things easy. So her only thing was pain here. Now let's see, don't run into the other imagings. Just see the clinical findings, and she's given her consent for being put on the platform. Severe tenderness there. See? You see, she's got a flexor, fixed flexor deformity. This is a psoas irritation. You got two big findings there. So you know there is a paraspinal problem, and psoas only tells you it's still a paraspinal problem. So when somebody comes with paraspinal problem, don't dismiss it off superficial cellulitis. There is a deeper grumbling there. Now, if you have a problem in the peritoneum, you will easily get anterior abdominal findings. But if you have a problem in the retroperitoneum, you are not going to get anterior abdominal findings, and the problem will be equally serious. You will only have findings in the peritoneum, in the posterior abdominal wall. So you had tenderness, you had edema, not only that, marked psoas abscess. So something which belongs to the skin as a cellulitis or an abscess is not going to produce psoas abscess. So there is a deeper issue. So the next thing is to take an X-ray. In an X-ray, you will find out whether it is the spine which is having the issue or whether it is the kidney. These are the structures in the retroperitoneum. So kidney, spine, and the pancreas. These are the famous three villains sitting there. Another one is your abdominal aorta. But your abdominal aorta, when it has a problem, usually it does not involve a psoas spasm because it will be a vascular event. Maximum will be a dissecting aneurysm. out and you're not going to get a zoospasm. Zoospasm will come in infective lesions like spine, your pancreas, or infection from the kidney. So the moment you take an X-ray abdomen, you have taken it for three things. One, to see whether there are pancreatic, you want to know the organ of origin, whether there is pancreatic or spine there is an issue. And not only that, you found a DJ stent. See, bilateral DJ stent. Not many patients will come and give history. This stent has been put 20 years ago. She has no clue after that what happened. No issues. Now she's come with the problem. We have to get down to the basics. You ask for a CT scan, and this time you will ask for a CT scan and look into the urinary system, and don't get distracted all over with your CT. So you'll be very focused on the urinary system. You can see the stents there. Yes. What are they doing to the kidney? See, both kidneys are almost irregular. But look at the left kidney. Not only irregular, but there is a halo of gas there. So it is a infection with the gas forming organisms. Not only that, you look at the psoas has got air pockets. Paraspinal muscles have got air pockets. This is the bowel. Don't worry about it. So you know there is a serious problem here. In fact, we lost this patient because of septicemia. Okay, now I told you about encrustation. If it is encrusted, you can't hang it off. What will you do? You need to remove this encrustation. That can be done with your laser. And how can you apply the laser here? By doing a ureteroscopy. You need to enter the urethra now, into the ureter now, and break down the stone. So that is how you'll be able to take it out. Fine. So ureteroscope is used only if stent is complicated with a stone or a encrustation inside the ureter. Otherwise, you can just do a cystoscopy here. You need not enter the urethra. You need not enter unnecessary spaces. If you can do something lesser than that and get the same benefit, stop with it. So you will do only a cystoscopy and remove the stent. But if the stent is encrusted or there is a stone, you need to move in here, break that stone with usually laser, and then able to remove the stent. So what is this thread? You see, thread is on one end. Just is like a copper T. This thread will be based outside the urethra, and sometimes even patients can remove it at the scheduled time. Usually they don't, so they will come back to your OPD. Now what I want to tell, look at the ends of the J. They are curled. They are malleable and curled, but you can straighten them over a guide wire, introduce it, and then remove the guide wire. So the ends will go and curl into the place where you kept them. So this end will be in the bladder, this end will be in the pelvis, and this thread will be outside the meatus. Fine. So it's almost self-retaining. Okay. Now your question was, how will you remove this stent? You have the DJ stent here. Would you do a cysto-ureteroscopy? There is no need, because you can make out there is no stone and it doesn't look entangled. It is an overkill. Unnecessarily you will be entering the ureter. It needs a lot of expertise, it needs equipments and other things. So unless it's complicated, there is a stone there which you want to break using some ablation device, you will not need an ureteroscopy. Now, could it be fluoroscopy guided? No, fluoroscopy guided is when you have a nephrostomy tract here. You can use a fluoroscope, put your instruments and yank this off. So, is it a cystoscopy? Yes, a simple cystoscopy will suffice. There are not enough clues here. Neither clues were given in the stem to find out your the option to remove the stone other than a cystoscopy. So your answer will be a cystoscope will suffice from the information available on the image and the stem. Any of the above? No. You have a specific modality of removing them. You cannot have a one size fits all and use whatever way you want to practice medicine. So coming to the end of this session, thank you all very much. I genuinely feel that every MCQ needs little more depth. It can't be just, thrown and given you the right answer. It needs little more depth, and I do my best to discuss the options also, so that this option can be done for a DJ stent, but not in this particular scenario. That is why I want you to pay some attention and go through these options. And number two, please don't rush through my presentation. When I'm talking about an image, stay in that image with me, so that your mind doesn't wander into the next image on the same slide. You will tend to get distracted. So thank you again, and I request you to subscribe, share and like, and also to remind you that I have a Telegram channel. Thank you.